All right, so let's set the scene. It's a standard Tuesday morning in clinic. The coffee hasn't quite kicked in yet. You walk into room 3, and there's your new patient. Let's say 45, maybe 50 years old. And they're just telling you they feel a little off.
Ah, the classic off patient. I know them well.
Right. It's all the nonspecifics.
Yeah.
A bit tired, dragging in the afternoons. Maybe they've put on 3 or 4 pounds over the last year despite, eating the same. Nothing dramatic, but it's enough to bother them.
Enough to impact their quality of life.
Exactly. So you do the right thing. You run the panel. You cast the net. And the labs come back. The TSH is sitting there at, say, a 7.5. But, and this is the kicker, the free T4 is dead normal.
Mm.
And instantly there's this reflex. You see that red number on the lab report. You see the fatigue in the patient's eyes, and your brain just goes, hypothyroidism. I have a pill for that.
The fix-it reflex. It is incredibly powerful, and it's something we're all trained to do.
It is. And so the question we're really wrestling with today is, should you actually write that prescription? Because the conventional wisdom, or maybe just the clinical habit we've all drifted into, says yes. But the data tells a much more complicated and honestly, a much more uncomfortable story.
It really does. And this is probably one of the most common dilemmas in primary care and endocrinology. We're talking about that very specific gray zone, the adult patient, new diagnosis of subclinical hypothyroidism, mild symptoms, and a TSH that is elevated but still below that critical threshold of 10.
To treat or not to treat?
That is a question.
And I think for a lot of us, the instinct is to treat. And let's unpack why, because it's not coming from a bad place at all. It's from a desire to help.
Absolutely. No clinician wants to send a patient home feeling like they weren't heard or, that their problem was dismissed. When someone says, I'm tired, and you see a lab result that could explain it, connecting those two dots feels like a win.
It feels like good medicine.
Yeah.
It validates their experience. It gives a name to the misery.
Exactly. And, levothyroxine doesn't exactly feel like a high-risk medication in our minds. It's bioidentical, it's cheap, it's generally well-tolerated.
So the logic is just, why not? Let's normalize the TSH. Maybe we prevent it from getting worse, and hopefully the patient feels better. It feels like a low-risk, high-reward move.
Right. You turn the red number green on the chart, and everyone goes home happy. But this is where it gets really interesting. When we actually look at the hard evidence for this specific group TSH under 10, mild symptoms, does the fix-it approach actually fix anything?
And this is where we have to look at the big placebo-controlled trials.
We do. And the hard truth we have to confront is this. The evidence suggests that for this cohort, immediate treatment does not consistently improve symptoms or quality of life compared to just observation.
Which is kind of mind-blowing when you think about how many millions of people are on levothyroxine for this exact scenario.
It is a massive disconnect between our practice and the evidence. We have this deep-seated assumption that normalizing the biochemistry, getting that TSH back to a beautiful 2.0, will automatically mean the patient says, Doc, I feel great.
But it doesn't.
But in mild hypothyroidism, that correlation is incredibly weak. Often it's just not there.
So you prescribe the pill, the labs look perfect, but the fatigue, the brain fog, they don't budge.
Often they don't. And what that implies is that for this group, the symptoms likely aren't being driven by the thyroid in the first place. That elevated TSH might just be an innocent bystander or maybe a minor physiologic adaptation, not the root cause.
So you're prescribing a daily medication with the whole burden of taking it on an empty stomach, waiting for your coffee, the follow-up labs, the pharmacy runs. For a result, that might just be cosmetic on a lab sheet.
Precisely. And we can't forget that it isn't just about no benefit, there's also potential risk. We think of levothyroxine as benign, but overtreatment is a very real thing. If you push that TSH too low, you start worrying about atrial fibrillation, about bone density loss over time, especially in postmenopausal women.
Okay, so the tension is really balancing this desire to improve quality of life against the very real risks of unnecessary medicalization.
That's it, exactly. Are we treating the patient, or are we just treating the reference range on a piece of paper?
So if that fix-it reflex is actually leading us down the wrong path, what's the alternative?
Yeah.
Because telling a patient we're going to do nothing that's a tough sell.
It's a terrible sell, and that's why we have to reframe the language. We are not doing nothing. We're practicing active surveillance.
Active surveillance. I like that. It sounds strategic. It sounds like a plan, not an omission.
It is a plan. It's a risk-benefit calculation. Since the benefits of treatment in this range are inconsistent at best, and the risks are real, the safest path is to monitor. We're tracking symptoms and thyroid function over time to see if a clear indication for treatment actually emerges.
That's a key distinction, I think.
Yeah.
We aren't dismissing the diagnosis. We are waiting for the disease to declare itself.
You're not.
Or not.
Because TSH can fluctuate, right? It's not some static number.
Oh, it fluctuates significantly. It's pulsatile. It has a circadian rhythm. It reacts to stress, to non-thyroidal illness. A TSH of 7 today could easily be a 4.5 in 3 months with zero intervention.
Really? Just spontaneously?
Yes. In fact, some studies show that up to 60%, 60 of these mild elevations normalize on their own. It could be transient thyroiditis, recovery from a virus, even just lab variability. If you treat on that first blood draw, you've just committed a patient to lifelong therapy for what might have been a blip.
60%. That is a staggering statistic. If we treat on day 1, we are literally medicalizing a temporary state for more than half the people. Exactly. And once you start the medication, the body's own production shuts down, so you never find out if they would have recovered. You've created a patient for life.
Okay, so the default is wait and see, or active surveillance. But medicine is never that simple. There have to be exceptions. When do we switch gears from surveillance to, okay, time to write the script?
There are definite triggers. The first one is what I call the hard threshold. If that TSH on repeat testing rises above 10.
Why is 10 the magic number? Is that arbitrary, or is there real pathology that kicks in there?
It's data-driven. Once you get above 10, the risk of progression to overt hyperthyroidism, where the free T4 actually starts to drop, is much, much higher. And more importantly, the likelihood of adverse cardiovascular outcomes starts to creep up. We see effects on lipid profiles, especially LDL cholesterol.
So below 10, the risk is mostly theoretical or symptom-based. Above 10, it starts to become organic and systemic.
Correct. At that level, the benefits of treatment generally start to outweigh the risks. So TSH over 10 is a pretty clear green light for therapy.
Got it. That's the biochemical trigger. What about the clinical side? What if the patient comes back in 6 months, their TSH is still 8, but they feel way worse?
That's the symptom evolution trigger. If symptoms worsen significantly, or if they develop something new, like a goiter, that changes the calculation. A growing goiter tells you the gland is failing. It's under significant TSH stimulation, and it's physically struggling.
So in that case, the anatomy kind of trumps the biochemistry.
It does, and in that case, a trial of therapy is very reasonable. But, and I can't stress this enough, it has to be a true trial.
Meaning there's an end date, there's an exit strategy.
Exactly. We agree up front. We're going to try this for 3 to 6 months. If your labs normalize but you still feel just as tired, we are going to stop the medication.
That's a hard conversation, though. Here's this pill, but just so you know, I'm probably going to take it away from you.
It is, but it's essential. Otherwise, you end up with millions of people taking thyroid hormone for symptoms that are really caused by sleep apnea or depression or iron deficiency. The trial becomes a diagnostic tool. If it fixes the numbers but not the person, the thyroid wasn't the problem.
Now, there is one massive, non-negotiable exception to this whole deferral rule. We have to talk about pregnancy.
Absolutely. This is the big red stop sign. Everything we just said about waiting, retesting, deferring, throw it out the window if your patient is pregnant or actively planning a pregnancy.
And this is purely a safety issue for the fetus, correct?
100%. In the first trimester, the fetus has no functioning thyroid gland of its own. It is entirely dependent on maternal thyroxine for neurodevelopment, for brain development.
So a mild deficiency in the mother could be a major deficit for the developing baby.
Exactly. The risks of undertreatment here are not the mom feels tired. The risks are potential cognitive deficits, increased risk of miscarriage, preterm birth. So for pregnant patients, the TSH targets are much stricter. We treat early and we treat to target. The wait-and-see approach is off the table.
I'm glad we clarified that. That is a board exam level trap, but more importantly, it's a huge clinical safety issue.
It is. A woman trying to conceive with a TSH of 5, I treat that immediately.
Which actually brings up another nuanced group, patients with thyroid autoantibodies, the TPO positive, Hashimoto's patients.
Right.
Does a positive antibody test mean we should pull the trigger earlier? Say TSH is 6, T4 is normal, but the TPO is through the roof.
It doesn't automatically mean start treating today if the TSH is still mild and they're asymptomatic. However, the presence of antibodies is a very strong predictor. It's like a crystal ball for future progression to overt hypothyroidism.
It tells you the mechanism is already there. The immune system's actively attacking the gland.
Exactly. So if I see high TPO antibodies, I'm not starting TILs right away on a TSH of 6, but I'm certainly not telling them to come back in a year. I'm monitoring them much more closely, maybe every 3 or 4 months. They're much more likely to cross that threshold of 10.
So antibodies are like a flashing yellow light. Proceed with caution. Watch the road.
That is a perfect analogy.
Let's pivot to the other end of the spectrum. We talked about pregnancy. What about our older patients or patients with a history of cardiac disease? I feel like the risks of that fix-it reflex are even higher there.
Oh, much higher. This is where do no harm has to be blinking in neon lights in your brain. In the elderly, or anyone with known coronary artery disease, the heart is very, very sensitive to thyroid hormone.
Because it drives metabolic rate, heart rate, contractility, all that stuff.
Right. If you overshoot and make them even slightly hyperthyroid, suppressing that TSH too low, you risk precipitating angina, a heart attack, or atrial fibrillation.
Which is obviously much worse than feeling a little tired.
Significantly worse. You're potentially converting a nuisance complaint into a life-threatening cardiac event.
So how do we adjust our thinking for, say, an 80-year-old?
We have to recognize the age-related shift in TSH. As we get older, the normal TSH range actually shifts to the right. A TSH of 6 or 7 in an 85-year-old might actually be their physiologic normal.
So treating them to get down to a normal of 2.5 is actually making them hyperthyroid relative to their own age group.
Precisely. You're giving them a biochemical youth that their body can't handle. It looks good on paper, but it's dangerous in practice. The reference range on that lab slip is usually based on a healthy 30-year-old.
That's such a crucial point. So for these patients, we lean even more heavily into deferral.
We do. And if we absolutely have to treat, say their TSH hits 12 or 15, we start low and go slow. We start with 12.5 micrograms, maybe 25, not the full replacement dose.
I want to circle back to the patient interaction, because this all makes perfect sense intellectually. TSH under 10, defer. But in the exam room, you have a person who just wants to feel better. How does their preference fit into all this?
It plays a huge role. This is where shared decision-making comes in. If I've explained the data, explained that the likelihood of symptom relief is low, and a well-informed patient still says, I really feel strongly I want to try it, we can do that.
So you don't just say no?
I don't. I say, okay. The evidence says this might not help. But if you understand that and you understand we need to monitor it closely, we can try a therapeutic trial. But I set the ground rules. We reevaluate in 3 to 6 months.
And the patient has to buy into that exit strategy from the start.
They do. And frankly, sometimes that trial is what convinces them. They take it, their numbers become perfect, and they realize, oh, I'm still tired. Maybe it really is my sleep or my stress or my diet.
That's a great way to frame it. The medication trial itself becomes a diagnostic tool. It rules the thyroid out.
In a way, yes, but we have to be so careful not to fall into what I call the mild TSH trap.
The mild TSH trap.
That's the trap of assuming that a TSH between 4.5 and 10 is the cause of any and every symptom the patient has. Fatigue, hair loss, weight gain. If we see a TSH of 5.5 and say, aha, that's it, we stop looking for other, more likely causes.
Right. We declare victory and we stop digging.
And that is a huge disservice. We might miss iron deficiency anemia, we might miss clinical depression, we might miss obstructive sleep apnea or perimenopause, because we've pinned it all on a slightly lazy thyroid.
That is profound. By treating the number, we might actually be masking the real clinical picture, or at least delaying the real diagnosis.
Exactly. The lab clinical mismatch is real. Patient quality of life is the only measure of success, not how pretty the TSH number looks.
Okay, so let's try to synthesize this for the clinician who's listening right now driving to work. What's the core rule they should take into the exam room with them today?
If I had to boil it down to a mental flowchart, it would be this. In an adult with mild subclinical hypothyroidism and a TSH below 10, the default rule is to defer.
Defer unless.
Defer unless. Number 1, the TSH rises above 10 on repeat testing. 2, their symptoms worsen significantly and you've ruled out other causes. 3, pregnancy is a factor. That's the absolute trump card. Or 4, after a long discussion, patient preference dictates a well-defined therapeutic trial.
And for pretty much everyone else.
For everyone else, doing nothing is actually an active evidence-based intervention. It's safety-first medicine. It respects the fact that the body often self-corrects and that our interventions are not without cost.
It's funny because we're trained to hunt, to find the abnormality and fix it. It feels counterintuitive to just stand down.
It does, but sometimes the best physician is the one who knows when not to act. It requires more confidence to say, we are going to watch this, than it does to just scribble a prescription to make the number go away.
That's a powerful thought. It puts the onus on us to be comfortable with ambiguity, to live in that gray zone.
And to be comfortable communicating that ambiguity to our patients, to say, I am not ignoring this. I am watching it like a hawk. But I am not going to treat you just to make myself feel better about your lab report.
So as we wrap up, I want to leave our listeners with a question. Think about your last week in clinic. How many times did you treat the number rather than the person sitting in front of you?
And how often does your own practice really reflect this watchful waiting approach? It's harder. It takes more time to explain why not than it does to explain why. But are we willing to invest that time to save our patients from a lifelong and potentially unnecessary medication?
It's the difference between treating a spreadsheet and treating a human being.
Ideally, we do both. But when they're in conflict, the human being has to win.
Always. This has been a really fascinating look at something that seems so simple on the surface, but is just packed with nuance.
It's one of those areas of medicine where the more you learn, the less you do. And that's usually a sign of maturity in practice.
Well said. We hope this helps you navigate that next gray zone case with a little more confidence. Thanks for joining us.
Until next time.